Now we're going to see the evolution of a solitary nodule. So a solitary nodule is a nodule found in chest X-ray, in a routinary chest X-ray, or that was done for any other reason that usually not associated to a symptomatology of solitary nodule. Alright, so first, if this was seen in a chest X-ray, if there are a lot of benign characteristics, no further evaluation. These characteristics are characteristics of a hamartoma, like calcification, cartilage, etc. If don't or else, then we need to ask for previous chest X-ray. If we have previous chest X-ray available and the size of the nodule have been stable for more than 2 years, then no further evaluation. If we don't have no previous chest X-ray available, or if there is growing of the nodule, next usually we do a CT scan, and if we see benign lesions in a low risk patient, low risk patient is, for example, less than 35 years of age, just serial testing. Or if, for example, we see benign lesions in a low risk patient but greater than 35 years of age, and the nodule is small, let's say less than 0.6 millimeter, then no further testing, even if there are multiple nodules. If there is high risk malignancy, resection. Many features of high risk malignancy characteristics that we will see it in a while. And if there is intermediate or inconclusive, usually we do a PET scan, positive emission tomography, or a biopsy. Now the PET scan is usually very sensitive if it is a nodule greater than 0.8 millimeters, because the PET scan detects the metabolism of the nodule or cells. If is a cell or a syncytia of cells that are very active, then we will see increased uptake of some glucose or some sugar, and so we will see that in the PET scan. But if the lesion is very small, even though it has a lot of metabolic activity, so it's taking a lot of glucose, etc., if it is very small, we will not see it. So we prefer to do PET scan for larger nodules. And the cytology, PET scan, and needle biopsy in intermediate lesions sometimes is not preferred to be used due to the increased risk of false negative. Because if it's an intermediate nodule and we have negative of this test, we usually don't exclude it. For example, if the cytology is positive, we do resection. But if the cytology is negative, we cannot exclude malignancy. Now, the characteristics of a benign lesion versus a malignant lesions would be, first, the risk of patients regarding the age. Here is less than 35, 40, 45, usually less than 35, and here certainly greater than 60, but sometimes we say that 40 or 45. Here we can put it as less than 30. And the gray area would be between 30 and 40. The risk of smoking, benign lesion would be usually seen in non-smokers, high or do smokers, yes, smokers. Lymphadenopathy, usually benign lesions do not have a associated lymphadenopathy. Yes, here lymphadenopathy is present. The characteristic of the lung, the benign lesion would be in a background of normal lung, and here sometimes the patient can have atelectasis because the lung cancer could be obstructing the airway. The calcification pattern here would be dense, uniform, like popcorn, and here would be like a spiculated calcification at irregular borders, spiculated or scalloped, and here uniform borders. Now, in intermediate risk, like intermediate years or intermediate characteristics, then usually the next step is to do bronchoscopy or transthoracic needle biopsy. If it's a central nodule, bronchoscopy. If it is a peripheral nodule, transthoracic needle biopsy. The benign lesions usually are less than 1 centimeter, and the malignant lesion greater than 2 centimeters.